Hi, everybody. Welcome to our Youth Leadership webinar series. We're waiting for some more people to come in, but I'll just get started with the housekeeping slides as people come in, and then we'll get started on the webinar. So this webinar, as I mentioned, is part of our Youth Leadership webinar series. This webinar is called Supporting Neurodivergent Students in Higher Ed and Challenging Discrimination, Human Rights and Social Justice. Our main presenter is Nev Jones, and my name is Shira Collings. I'm the youth coordinator for the National Empowerment Center. I'll be moderating, and I'll also present a portion of the presentation. I am so thrilled to have Nev with us and so thrilled to be presenting on this topic, and so looking forward to getting started. I'm just going to go over some housekeeping slides before we start. So this webinar was developed in part under a grant from the Substance Abuse and Mental Health Services Administration, U.S. Department of Health and Human Services. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Closed captioning is available. You can click on the CC or more to view closed captioning. You can also view the entire transcript of the meeting by clicking on Show Transcript. And this webinar will be recorded. The recording will be posted to our website at power2u.org. If you do not wish to be seen on the recording, you are welcome to turn off your camera. And we will be posting the PowerPoint slides and sending those as well. At the end of the webinar, there will be a Q&A session. You're invited to ask questions at any time through the chat function, and we will do our best to answer all questions. If we don't answer questions, you're welcome to email us. Our email is listed on this slide, info4@power2u.org, and we'll do our best to get back to you. You're also welcome to make comments using the chat function. We encourage you to introduce yourselves and share where you're coming from, and for this to be interactive. So we'll now go ahead and get started, and I'll turn it over to Nev.
Okay, I'm already unmuted. Okay. Hello, everyone. I'm just going to get the PowerPoint up. Okay. So I will go ahead and just dive in just to our overarching goals and agenda, so you have a sense of what we're covering here. We'll start with intros, and Bowen Cho, who's an incredibly amazing emerging leader and activist in this area, unfortunately just had last minute conflicts and wasn't possible for them to be here. So we still have them on the intro slide, but it's just Shira and I. So the focus really that we selected, and I think kind of even more so, given that it's the kind of Shira and me component that we're now presenting, hopefully we'll be able to bring Bowen on just on a later follow-up webinar. Really kind of focuses on coercion in the context of campus mental health. As we will explain or discuss, certainly coercion, coercive interventions are not the only problem in terms of what is arguably going wrong in terms of campus mental health. But it's a really important area, and one that often gets very little attention. And is often sort of invisible, especially in terms of the broader public. So after the intros, we'll just do some kind of background on the broader kind of problems or challenges that neurodivergent or disabled students face on campus. And then just briefly explain our rationale for focusing on involuntary interventions and coercion in this webinar. a little bit of general background on involuntary holds and commitment in the United States. And then we're going to talk about a research project that Shira and I and others did while we were all based in Florida. 2 different projects, one looking at experiences of involuntary commitment. And for today, we're focusing on the college students. And then mandated leaves of absence or involuntary leaves of absence. That's students who were placed on an involuntary leave by their university. So that's the second project. And this was really a project that Shira led and developed. And then just kind of a final slide, final reflections on, how we might move forward, action steps and recommendations in terms of changing campus policy and systems. Okay, so intros. Shira, anything more that you want to jump on and say about yourself?
I think you covered it. I'm the youth coordinator at the National Empowerment Center, and I have worked with Nev on a number of research projects. And so I'm excited to be sharing some of our results. I also work as an eating disorder therapist, as that's clinical work in addition to my peer role.
Awesome. Thanks, Shira. I will just take this moment to say that Shira is truly amazing and multi-talented. And I don't think her work on the sort of research side has necessarily been kind of featured on an NEC webinar before, but really all amazing, all the different things that Shira brings to the table in terms of her talents and range of skills and insights. And then just in terms of me, I am an assistant professor in the School of Social Work at the University of Pittsburgh. So I kind of now wear multiple hats. My interest in campus mental health, especially around the issues we'll be talking about here, started back when I was a student. And so the first graduate program I was in, I was on 2 separate occasions, first actually placed on an involuntary leave of absence, and then actually terminated from the program for reasons directly tied to psychiatric disability. In my case, I had been recently diagnosed with schizophrenia. And then during the same period, involuntary hospitalization, while a college student. So my experiences, definitely motivate a lot of this work. As a faculty member, I have seen the other side of it, just in the sense of the challenges, even for a faculty member who is really dedicated to universal design and more radical approaches to accommodations and disability equity, and how hard it is because of the systems that one is trying to work within and running up against, as well as student of disability offices are really challenging, even from the faculty perspective, in many cases. In other words, when one is actively trying to advocate for one's own students for more accommodations. So I'm like very, kind of very aware of, how hard it is to actually kind of move the dial on some of this. And same goes for various forms of involuntary and coercive intervention. And then Bowen, who's not here, just do want to shout out to their project, Neurodivergent U, and the link is there. If anybody is not aware of Neurodivergent U, please check it out. It's already an amazing website, and really lots of plans to build and expand and really kind of fill a gap in what is otherwise available here in the States. Okay, so big picture background here. So college education, and probably most of you are aware and have seen news stories kind of speaking to the eroding value of a college degree. In spite of all that, student debt problems as well, right? But in spite of that, research tells us that college education still remains one of the most reliable pathways to to career mobility, socioeconomic mobility, moving up. And yet it is really kind of out of reach for very large numbers of students from high poverty backgrounds, students from first generation backgrounds, and those with complex, often highly stigmatized disabilities. So for example, schizophrenia, BPD, autism, complex PTSD, other personality disorders. And we use those terms not to, necessarily imply that there's some kind of scientific validity behind them, but because when you look at statistics and how statistics are broken out, we often see really, really abysmally low rates of college access, completion, and graduation for folks, depending on the diagnosis they've been labeled with, and a lot of that reflecting social processes, the level of kind of discrimination, exclusion that may be tied to kind of stereotypes and prejudice about a particular condition, as well as the extent to which some of these labels may index complexity of people's experiences, challenges, how they're being impacted. A point we will also make is that there's certain diagnoses that often campus mental health authorities are comfortable talking about, and others that really get pushed to the absolute furthest margins, and that is a problem. Post-secondary institutions have traditionally responded to these more quote unquote serious student mental health issues, not by inclusion and integration, but by removal of the student. So whether that's removal of the student from the dorm, removal of the student from campus entirely, permanently, or temporarily in the form of, say, a short-term emergency hold or involuntary hospitalization. And through the minimization of real or perceived campus legal liability. So the logic is often, as long as that student is matriculating, legal risk is attached to the student and the university and campus administration. And so just, kind of get them off campus, and now it's no longer the responsibility of the campus or institution. Dedicated educational supports for students with disabilities, again, especially those kind of traditionally labeled as serious mental illness, are incredibly scarce. So rates of high school college attendance and college graduation are the lowest of any disability group. If people don't know this, this is already true and the best, most comprehensively documented at the secondary school level. Rates of high school non-completion for students with, of course, on the child side, the label is SED, are the lowest of any disability group. So it starts early and it just kind of continues across the educational continuum. Speaking just a little to racial inequality and intersectionality, as I'm sure most of you are aware, there are huge inequities in this country in terms of college enrollment, college engagement, graduation by race, with Latinx and Black Americans, right? Really experiencing kind of significant access barriers, fewer supports, financial barriers, all along the way, as well as kind of this backdrop of structural racism and exclusionary policy. And it's a bit more challenging to find more kind of comprehensive research that really looks at intersectionality in the college student context. So there's some stats that are available just for disability, stats that are available by race, but that don't factor in disability, that don't break disability out in a meaningful way by type. So physical disability, learning disabilities, everything is just conflated together in some studies, but everything we know in a converging way in terms of the research literature points to really, really stark inequalities facing Black youth who are labeled with SED, SMI when it comes to college education. Probably the single most intersectionally excluded group. Just briefly, I want to speak to the limitations of the Americans with Disabilities Act, because I think often there's a perception that the ADA provides much more expansive and robust protections than it in fact does. So in fact, already in the wake of passage and initial implementation of the Act, legal scholarship swiftly started to emerge, speaking to real kind of problems of implementation and then erosion of the intent of the ADA through conservative judicial rulings. And there are failures across the board that impact all disabilities, and then particular gaps in the ability of the ADA to really make a difference when it comes to mental disabilities. So some of that takes the form of individuals with disabilities or with psych or mental disabilities trying to bring lawsuits or grievances forward, and judges, deferring to universities and employers to a really extreme degree, and establishing judicial precedent that really just overwhelmingly defers to, campus administrators or employers. There are also a lot of loopholes and limitations built into the ADA, sort of legal terminology and language used that really kind of allows, in the higher ed setting, campus administrators to really refuse and get away with refusing a whole host of potential accommodations. And then some legal scholars have really called attention to the fact that the ADA passed relatively easily, but not actually with widespread public support. It was just kind of seen as a non-issue for a lot of the public. It's not an issue that anybody cared about particularly much one way or the other. But when it comes to implementation, that lack of public support is really, really problematic, and is one explanation of why we see so little uptake, minimal compliance implementation often, and no real kind of public push to, in a more robust way, amend the ADA. There's been one set of amendments that passed that arguably has made relatively little difference for psych disabilities or mental disability issues. And so, what happens as a result? Universities that receive federal funding are required to implement the ADA, but often the underlying kind of approach is premised on minimal legal compliance. Accommodation processes and protocols that favor these really sort of easy, straightforward accommodations like extended testing time that in some cases may be helpful, but an awful lot of the time don't even begin to really address the barriers that students with, kind of complex and diverse disabilities are facing. And then, unwillingness often to even try to apply the ADA as fully as it could be to other areas of campus policy, student housing, financial aid, scholarships in some cases. The decline of dedicated supported education programs, and this webinar technically is part of a supported education mandate that the consumer and consumer supporter technical assistance centers had around supported education. But the reality is that there are very few supported education programs left in the US. They have declined precipitously since the 1990s, which was sort of the peak of supported education. The reasons for that are complex, but funding has a lot to do with it. And there are silos and disconnects around vocational rehabilitation, and this varies by state, but where in theory there is funding available, that mental health providers are blocked from or unable to access on behalf of students with psychiatric disabilities. So again, you can see really stark disparities in some places between physical and neurodevelopmental disabilities in terms of access to voc rehab funding and resources. And supported education, just to explain, was really a kind of a family of programs first developed really in the late 80s with the dedicated focus on getting people back to re-enrolled in or enrolled in the first time in higher education. So higher education as a primary kind of psychiatric rehabilitation goal. This was the sort of the period of deinstitutionalization, or kind of really following the peak of deinstitutionalization, when providers in this country were trying to figure out ostensibly how to do community integration instead of, the preceding decades of having just kind of warehoused people in state hospitals and institutions. And so in many ways, it was kind of a very, very progressive idea and thinking. And the programs that were developed in the late 80s, early 90s tended to be kind of quite intensive. Study skills training, really kind of meeting people where they're at and trying to make sure that they really have the skills and knowledge that they would need to be successful in a college environment. GED completion, if that's an issue, and then all aspects of sort of actually getting people into schools, application supports, filling out forms, figuring out financial aid, that sort of thing. Once students are matriculating in a program, potentially quite intensive educational coaching, on-site support, staff or providers in the program who could kind of come on campus, assist in a navigational kind of way, as well as peer mutual support groups, less as like kind of peer support in the mental health sense and more sharing experiences around challenges in a campus environment, sharing study skills, tips, like that sort of thing. So again, this is kind of one area in which, in theory, this family of programs might have been much more widely implemented, might have made or be making more of a dent in terms of the inequalities we see in people's kind of access to higher education. But really, we just see a handful of these programs left in the US. And then we have entered an era of widespread threat surveillance, which is particularly pronounced on college campuses, although you see versions of this also now in public schools. So just brief history here is that since the early 2000s, and we had, kind of a wave of campus shootings. These were in many cases attributed to mental illness, quote unquote, or linked to mental illness. And this led to both federal and state policies. In some cases, it is the state's kind of higher education association or board of trustees. So there's a variety of layers to all the regulations that now exist, but requiring threat detection and assessment on college campuses. Today, 2023, virtually all campuses support online student of concern reporting pathways. On a subsequent slide, I just have some screenshots of different student of concern threat reporting forms. Once flagged by these mechanisms or by direct outreach, for instance, a student or a family member could directly call the campus counseling center and be rerouted. Students can be assessed. And, as things kind of escalate, potentially involuntarily committed or placed on an involuntary hold, that language varies by state, suspended or terminated. And, on the more, kind of helpful, proactive side, some campuses do now have programs to really provide more intensive advocacy and support to keep the student integrated rather than to eject them from the campus kind of environment and campus community. And then I just want to kind of add for context that I don't always, like, sometimes I think there's just probably a lot of kind of popular in the general public misconceptions about who is being involuntarily hospitalized and why and for what reasons. But I just wanted to include this figure, which is from Allegheny County, where Pittsburgh is, where I live, just to kind of show you that really involuntary commitment peaks or plateaus in young adulthood. This is the time when people are most at risk of being involuntarily hospitalized. And for minors, most involuntary commitments in states where we have data are actually being, or a very large proportion are being initiated in schools, not outside of schools. Rates notoriously plunge in the summer when students are out of school because so much of that initiation is school-based. And I and others, and even, attempting to get some of this data through Freedom of Information Act requests have failed. So there is very little public reporting on rates of involuntary hospitalization initiation at college campuses. I have informally heard quotes from administrators. It's a high rate. Again, there's sort of no reason to believe, or nothing in available data that suggests that students or that young adults who are not college students are more likely to be involuntarily hospitalized. It's very likely that it's the reverse, because in the campus environment, people are under kind of constant surveillance in a really different way. You're being kind of watched by people. Faculty can get concerned, right, even if a student doesn't show up for a couple of weeks. So there's just nothing, I think, kind of close to that same level of monitoring if you were out in the community working part-time. These are just some examples, and literally you can just Google University Student of Concern reporting, and hundreds of them will pop up. So this is just to kind of show you the interface. The one at the back is the University of Central Florida. One of these is Texas A&M, and then Western Oregon University. So just to give you different parts of the country, same idea. I'll just read you the Texas A&M one. Oftentimes after a tragedy, people come forward with information and observations that in retrospect may have signaled a larger issue. This information, when viewed collectively, may be helpful in preventing tragic events and initiating assistance to an individual. Texas A&M is committed to a proactive approach and needs your help. As a member of this university community, if you observe any behavior that is concerning, you may report the behavior using the online report form or by contacting one of the special situations team members during business hours. The special situations team is comprised of university faculty and staff charged with helping students, faculty, and staff who are exhibiting concerning behavior. And I in part did use the Texas A&M one. Bowen and I, this is part of a fellowship that Bowen has, have been somewhat successful in Freedom of Information Act requests for student of concern reports, and we have thousands of them from Texas A&M. So this is the interface, and then we are actually seeing exactly what it is people are reporting on the other side. And I'm not going to kind of say too much about that, but suffice to say, every year it expands the amount that people are reporting. It's an enormous range of things now that people are reported for. Not all of it is mental health, but certainly there is now this coupling and this linkage of any sort of quote unquote unusual mental health behavior as something potentially to be reported, and that reporting being explicitly linked to quote unquote tragedies. So we're really, again, kind of strengthening the connections in people's minds between psych disabilities or mental illness, and dangerousness, violence, risk, unpredictability, protection of the campus community, et cetera. The chain of escalation, and I kind of already mentioned this, is that often things start with a student of concern report, either via an online form or, direct to a person, to a team member. If it escalates to the next level, that means there will be some kind of assessment or wellness check being, often involving campus police officers. And if it escalates further, that can lead to an involuntary hold, an emergency hold, which in some states is already categorized as a form of civil commitment. In some states, civil commitment is kind of the next level up once there is a judge's order mandating somebody into inpatient treatment. And then even if it's just an involuntary hold, this often, and in the project Shira and I did, many people described immediately, sometimes before they even were physically discharged from the hospital, receiving notification from the university that they could no longer return to campus. Dorm lockouts are not uncommon, as are account lockouts. You can't access your account, you can't access your student email, you can't register for any classes, you can't log in some cases, to course systems. And then, dorm lockout, you instantly can have no access to your dorm, or if you're living in some other kind of student residence. Or, say it's your virtual student or something, just it's an immediate involuntary leave. So that's, that's kind of how bad it can be. It doesn't always escalate in this way, but it can, and when it does, it can be extremely damaging. And so why, of all the areas, of all the sort of problems, right, are we focusing on coercion? I think kind of one is that this issue is not getting the attention that it should, I think, among, kind of involved mental health activists. Psych survivor activists, of course, are very aware of issues of coercion, but I think in terms of the broader campus community, folks who are funding work on college campuses, it's really kind of a pretty decentered issue, or simply not recognized at all. And we're just not really, therefore, having conversations about it. The impact can be really negative. That's not to say that it always is, but it can be very, very damaging. And in some cases, as we found in the qualitative work, which we'll be describing, life-changing. It completely fundamentally changed the trajectory that somebody was on. People might drop out of college entirely, feel such deep shame that they can't show up on the college campus again, or such sort of kind of unprocessed anger with administrators that they simply can no longer be in the space, depending on their background and financial status. That might mean that they just give up on college entirely. So just a lot of really negative things can happen, and there have been a couple high-profile cases in which completed suicides were explicitly linked in suicide notes to involuntary leaves of absence. In a more indirect way, fear of involuntary intervention leads to avoidance, non-disclosure, let's say, of kind of suicidal thinking. And this is often never even documented. So how high the rates of this, in fact, are among college students, high school students, we don't know. I will say that, like, going way back in time when I was a college student at the University of Oregon, pretty progressive West Coast campus, pervasive word on the street was you would not go to campus counseling for any reason and ever mention self-harm, ever mention anything related to suicide, or you would be hospitalized immediately. So most of my friends would never have dreamed of showing up. And this was just like kind of, just widely understood by essentially everybody that I knew, and nobody was documenting that. So there's no data on how big those numbers really are and how many people are being impacted and affected. And then this use of kind of threat language, surveillance, these kinds of coercive responses, responses premised on this idea of remove the person, reject, eject them, rather than support them within the campus community, really contributes to and reinforces a particular, obviously very kind of stigmatizing set of narratives about, whether we want to call it mental health, illness, disability. So again, just to restate this, it really positions quote unquote mental illness as this primary source of threat, of danger, of unpredictability, of instability. And again, it presents a certain kind of solution to that problem: coercion and removal. So in even broader ways, we're talking about, by definition, college students then who are exposed during this pivotal developmental period of life to this kind of thinking, and it's reinforced, it's normalized, and it's endorsed by higher education institutions, which might, otherwise be looked up to as, kind of hubs of social justice, intellectual life, activism, etc. Okay, I'm gonna go through this really briefly. So this is just a little diagram I created, as a reminder, and this very much includes campus environments, right, of the many different ways a student in this case might end up involuntarily hospitalized or experiencing police involvement. And so, at every juncture, police can end up involved. Mobile crisis units may not have the capacity to provide transport, including, and there is such a thing, that folks, not everybody here may be aware of, but there are now campuses that have dedicated mobile crisis outreach. But that still often don't have the capacity or don't have the authority to transport. So they would just call the police, law enforcement in to transport, and potentially then a student is handcuffed, even if there is the intermediary intervention and initiation of the mobile crisis team. Involuntary commitment laws in the US vary enormously. So, you have to study the laws where you're living and working. A distinction that generally holds in some form is between emergency holds or examinations and kind of full civil commitment. In some states, one of the distinctions here is that in an emergency hold, you can be detained for the purposes of an examiner evaluation, but you cannot be forced, for example, to take medications. Under a civil commitment order, then sort of the next level of escalation, you would be compelled into whatever the recommended treatment was, including most often medications. In some states, that's not true. And upon an emergency hold, you can already be compelled to take certain medications, or you can be subject to involuntary injections, that sort of thing. And then there's usually extended commitment options beyond. So whenever you reach the maximum time under the first level of civil commitment, providers, hospitals can apply for an extension. Who can initiate these emergency holds? Again, a lot of variability in virtually all states. Law enforcement can initiate with no prior authorization or additional authorization needed. Physicians and psychiatrists, MDs, can initiate in most states directly, even in states that otherwise require pre-authorization. Licensed mental health providers, school principals, it's uncommon, but it exists. Individuals who are more often forced to kind of petition or required to petition or seek some kind of prior authorization from a judge or third party, like a county entity, family members, quote unquote, concerned citizens. And in some states, mental health providers and healthcare providers who don't have an MD fall into this category. I'm not going to spend very much time on it, but just so you kind of realize the state variations and kind of permutations of who can initiate an involuntary hold and with what level of prior authorization. It's very variable. Variations in hold criteria, I think, is another thing that often is sort of insufficiently understood. 5 states, for example, allow recent suicide attempt even with no active current evidence of suicidality. That is sufficient legal reason for an involuntary hold. This is just kind of some of the other categories. And in some states, mental illness, quote unquote, which sometimes is and sometimes isn't defined by statute, is required. In other cases, it's not. Risks. So obviously, literally death or physical injury, emotional trauma, which I think is even more common. And again, this really comes out in the interviews we did, right? So again, and these are with college students. So this is not some other population. This is happening to college students. This is happening to elementary, middle school, and high school students as well. The trauma of being handcuffed, of being walked through public facilities in handcuffs by police officers, use of force. And then once people are in psychiatric facilities, experiences that can include seclusion, restraints, forced injections are probably the most common additional layer. And then once people are discharged, financial, there can be huge costs. The cost of the hospitalization alone might force a student out of school. And again, it really depends on their insurance status, what they can get covered or not. But we heard, Shira and I and the others involved heard horror stories just about the financial implications of even a brief involuntary hold. Disruption to schoolwork and family. Often students feel the most stressed during finals or in the week before finals. So then they're back and having to deal with, massive disruption there. And then obviously psychological, leaving traumatized, feeling distrust and fear of providers, fear of disclosing, fear of actually kind of seeking help or trying to find support. Just going to skip over this. And then just kind of briefly, and as a researcher myself, I'm often speaking to audiences that are not very receptive to the concerns I'm trying to raise. We can't randomize people for ethical reasons to receive or not receive involuntary hospitalization. And so the normal way that we try to establish a causal relationship between a thing and what follows isn't really possible. So researchers have pursued a variety of kind of creative quasi-experimental ways to try to tease out the impact of involuntary hospitalization. But here are 2 references. That one, which, really, really rigorously conducted study that essentially links perceived coercion during hospital admission with suicide attempts after discharge, even controlling for all kinds of covariates, all kinds of things that you might say would otherwise explain that relationship. And then the 2021 paper, again, used what we would call quasi-experimental methods. And basically their very conservative interpretation was that they could not rule out the possibility of iatrogenic effects, that is direct harm of involuntary admission itself, above and beyond what the person was actually experiencing, above and beyond any risk that would be attributed to their actual mental health or the crisis that they might have been experiencing on admission. So there really is not, on the flip side, research speaking to the effectiveness of involuntary commitment, perhaps shockingly, but this is another thing that I think the general public just does not realize. There is an assumption that this is beneficial, that we are, as I've been repeatedly told, saving lives, and just kind of ignoring the reality that we, in many cases, may be doing the opposite. What we have heard in terms of heard and seen in the work we've done on college campuses, campus law enforcement are often involved in initiation or transport, and probably the two other biggest places you see initiation are student health center staff, campus counseling center staff, and in some universities, dorms and residence assistants or supervisors in a dorm who at least initiate the reporting, and maybe like call campus police in. And then again, just as a reminder, that can lead to involuntary leaves of absence. And then once a student is on a leave of absence, universities generally have authority to require them to meet certain conditions in order to be reinstated. And those can be incredibly difficult and punitive. So I know a student that was required to enroll in an intensive outpatient treatment program that was like full days, 4 days a week, while also somehow having to register for full-time classes in a small liberal arts class or liberal arts campus in which there were few evening offerings. So it almost was logistically impossible to even do, not to mention the cost of the IOP, which was not covered by insurance. So it can be really prohibitive. The conditions are such that it effectively prevents the student from returning. Okay. Just gonna like pause a second. If you have any questions, type them into the chat. I mean, we'll wait till the end for Q&A. And I'm just going to kind of race through just a little bit of the background on involuntary commitment, because I think that the newer piece of this, which Shira will be talking about, is the experiences of mandated leaves of absence. But we had 2 projects, interviewed 40 youth and young adults about involuntary hospitalization, and then interviewed 23 current or former college students who had been placed on involuntary leaves, most but not all of whom were involuntarily hospitalized before the involuntary leave. I'll just skip over kind of the police involvement. Just impact of involuntary hospitalization, I think for this audience, probably nothing all that surprising, but you know, just so you have a little bit of a kind of more visceral sense of what we were hearing repeatedly, stuff that under normal circumstances would really disturb anyone, right? So being involuntarily hospitalized that one time was enough to make me shut out all help from figures like therapists and school workers, my parents, for fear of going back to that place. I'm just not, I don't know, like, okay, if anyone were to ask me, like I set up an appointment with the counseling center, if anyone were to ask, I feel like I couldn't really explain what's going on, just because I feel like if I say something that's even the slightest bit a problem or something, they would refer me somewhere and just notify somebody, and, you know, the participant would end up in the hospital again. I definitely don't ever want to get involuntarily hospitalized again. If I ever got to a point where I was suicidal again, I think I would be too scared to get help because the whole experience terrified me. And I always tell my parents, no, that didn't scare me. I'd be fine. I'd get help if I do it again. But I don't think I would. It was terrifying. And what she was experiencing too, again, combination of police transport and voluntary hospitalization. So it just goes on and on. I mean, we were just hearing story after story like this. So it's just a few years ago. This is not, you know, like 20 or 30 or 40 years ago in some other historical era. But treatment was widely described as dehumanizing. Analogies to prison or jail were almost ubiquitous across all these interviews, 60 plus interviews. Dehumanization, feeling judged on moral grounds, having to learn to lie to escape from the hospital, and that learning to lie carrying over to post-discharge behavior. So I'll just read one quote here. The first thing I learned as soon as I was put into the hospital was that I couldn't actually talk about what was wrong, because then I would be taken against my will somewhere and my parents would have to pay for it. So as soon as I was told I couldn't leave, then I shut out even more. And I'd already been reluctant to hand out information, but at that point it was, I'm just going to say whatever I need to get out to anyone, to my parents, to therapists, whatever I need to do to make them think nothing is wrong. And again, I find a lot of this chilling, right? Really, really chilling in terms of this is what our system and our current policies are doing. How can anyone want this to be the sort of the messages and the lessons that we're imparting on, youth and young adults? Okay, and now I'm going to turn it over to Shira.
Okay, thank you so much, Nev. I really just appreciate all that you shared, and I think these are such important things that we need to be more aware of. So I want to talk a little bit about mandated leaves, and I'll try to go through this relatively quickly because I want to make sure we have time for Q&A. I want to hear what you all have to say and the questions that you all have. So these are some of the results of our mandated leaves, the portion of the study that focused on like mandated leaves, not just involuntary hospitalization. The overwhelming majority, that's 87% of those interviewed, described deeply negative experiences and impacts. It was something that was highly distressing and traumatic. Some of the things that were described about the mandated leaves process included not having any forewarning, feeling blindsided, just kind of suddenly being told they had to take a leave, suddenly not having access to campus facilities anymore, callousness and indifference from school administration. It felt akin to discipline. Many people described it as feeling like a punishment, like not a form of support since it was mandatory. They didn't feel like there was any due process, or if there was, it was more of a performance. It didn't actually feel like their rights were being respected. So here are some quotes that we have from participants. In the hospital, I was determined to go back. I kept asking for my schoolwork and stuff to be sent to me. And it was, but then one day they sent me a letter and they said, "We have withdrawn you from your classes." I was still in the hospital at the time. I also don't believe it was explained to me exactly what was happening. It was literally like I was told that I had to be out of campus housing in 3 days. There was no explanation. There was no explanation of a process of how this was to work. It was basically like one person made a decision, and that was the law. And this another quote, I got checked into the hospital and spent a couple weeks getting stabilized and recovering there. Then started the whole process of meeting with the dean of students, tried to get back to campus, etc. I had been coordinating with my professors and my psychiatrist at the time, and the doctor from the school hospital all wrote a note saying, we all think it would be good for that participant to go back to school, get back in the dorm, have social support from that structure, etc. But the dean of students would not let me come back and forced me to withdraw for the whole semester. I was not allowed back into the dorm. Next slide, please. So we want to talk about some of the impacts of this, and one major impact that we really heard in these interviews was shame. So some quotes illustrating that include, in the immediate aftermath of being told I can't return to my apartment, I felt really ashamed. I felt like there was something wrong with me and that people looking at me would just know that I was labeled as dangerous or a liability and I wasn't allowed to live on campus. And I was walking around from appointment to appointment, trying to get back into my apartment. I felt like everyone I passed was looking at me and staring. Obviously, that wasn't the case. Nobody knew who I didn't tell, but I just felt an overwhelming sense of shame, and that lasted for like several months afterwards. Another quote, when it happened, immediately all these people start getting involved, sort of getting involved and not knowing what to do. I just felt like dying. Like I didn't have thoughts of like a plan or so, but that's the only way I can describe it. It was just like the shame was very, very big. So I just wanted to die. And I will just say, this impact here really resonates for me personally. I just want to kind of share a little bit of my personal experience here, which is, I have faced barriers in educational settings, including leaves of absence and mental health issues that caused people to question whether I should be continuing in graduate programs. And this sense of shame still haunts me. I just applied for licensure as a therapist, so I've been out of grad school for 2 years, but I still wonder all the time, like, do I deserve to be in my profession? Am I too broken or seen as something so wrong with me or abnormal to like even be in this profession? Do I even deserve this license? And so this is very, very real. Nev, I know you just popped on, so did you want to add anything?
No. I just didn't realize I had inadvertently turned off my visual. I was just
Okay.
being back to provide solidarity and support in visual form.
Thank you. Next slide, please. There was also an internalized sense of failure. My identity, it made me feel like a sick person, sick in a very negative sense of that word, not just mentally ill, but just a sick person, someone who can't be trusted with children, can't be trusted with any responsibility, someone who's just messed up in the head. All the negative connotations that come with being a sick person in this society, all the negative stereotypes. I internalized that, and I felt like I'm this sick person who doesn't really have a future. More broadly, very quickly, I went from being somebody who was doing very well in my PhD to not believing that I would ever work again, work of any kind, let alone academia. That was absolutely absurd, just totally absurd. It completely changed my view of who I was. And again, can totally relate, can support that this is real. I definitely struggle with us all the time. I'm like, any minute someone's going to tell me I shouldn't be a therapist or I shouldn't be working, I shouldn't be in a leadership role in a nonprofit. When is that going to happen? How have they not caught on? And this just, I think it just kind of stays with you, and that's what we see in the research. Next slide, please. Distrust of academic institutions as well as providers was something else that showed up in the research. The forced leave made me really detached from the school and really mistrustful of any relationships with school administrators, with professors there. So I didn't feel like I could go to people for help, whether that be emotional or school help. I didn't trust that any professors or administrators, I didn't trust any professors or administrators ever again. There was that. I felt like I couldn't. And this next quote, it's something I will always struggle with, I think. I have deep wounds from how I was treated, and I will never, ever trust any administrative people at universities again. Next slide. So questions that this raises. Punishment versus support. We saw a lot of parallels and overlap between responses to distress. So institutional policy, law enforcement, providers, administrators, hospital staff, and we saw a lot of parallels between those kinds of responses and punishment. There was a reliance on processes and systems, law enforcement getting involved, campus police, lockouts, that are in fact primarily constituted to respond to misconduct or violations of the law. So people felt like they were treated like they were breaking the law, and not like they had a mental health issue that they deserved support around. And I just want to say too, the fact that people who break the law are treated in this kind of dehumanizing way is also not okay, and also really messed up, because often people who break the law, there are systemic issues there too that we need to be addressing. And this is not to say, oh, well, people who break the law should be treated in this dehumanizing way, and people with mental health issues shouldn't. Like these are issues that intersect and should be really they have a lot to do with each other, and everyone should be treated in a more humanizing way. So this research asks the question, what changes would be needed to fundamentally alter the logics of response, and not just remove particular actors? So not just removing the police, but then say mental health is, the mental health system is fine, or vice versa, but really how can we fundamentally change the response that we have? Next slide, please. So across 63 interviews, there was a virtual absence of any attempts or policies aimed at providing support in the processing of the actual or potential harms of involuntary commitment and or mandated leaves of absence. Overwhelmingly, youth, young adults, and students were left to come to terms with these experiences on their own, which again is just so real, something I can relate to as a youth who's experienced this. There's just not a lot of support in recognizing these experiences as traumatic and deeply harmful, and things that leave an impact psychologically. It's just like, this was for your own good. So, just be grateful, and don't ever talk about it again. Next slide, please. So in spite of these huge impacts that we've seen in our research, there's really no known research or reporting on mandated leaves of absence. Only a handful of US states report statewide data on involuntary hospitalizations. There's no comprehensive public reporting of law enforcement involvement in any kind of disability-related deaths, injury, or legal escalation. And across the board, negative impacts are under-researched, or just not in the literature. Again, it's just assumed that this is like a good thing, it's for people's own good, and we don't think about researching how it could be harming people. Next slide, please. So our recommendations, and I'll kind of summarize, and Nev, if you want to jump in here. So one recommendation is to increase public understanding and awareness of the realities of ableism, coercion, and exclusion on college campuses, including impacts on students with more stigmatized diagnoses that are not really being talked about as much. And then we really think there needs to be policies and systems that address the complex forms that direct and indirect gatekeeping takes in higher education. So exclusion because of restrictive admissions criteria, de facto exclusion because of socioeconomics and family responsibilities, weak implementation and interpretation of the ADA, which Nev talked about earlier, stigma and exclusionary attitudes, use of direct or indirect coercion, and failure to invest in more comprehensive supported education programs. So Nev, did you want to jump in and share more about some of these recommendations?
Just to say that, it's all synergistic, and I think, there's no easy fix because it's across all these different layers, so many things that function to really keep people out of higher education, keep them out of status professions referring to things like medicine and law, where there's even additional layers of scrutiny, including sometimes explicitly people's psych backgrounds, their histories, if they've ever been involuntarily hospitalized or committed, that sort of thing. Yeah. And then I can just keep going quickly. This is the last slide. So just, obviously alternatives to coercive intervention, and hopefully maybe we could spend some more time just discussing this. People in the audience maybe have questions, ideas, things they've seen. There are much more kind of holistic peer mentoring and community building models in other areas of campus life. So where the focus isn't just on clinical aspects of experience and clinicalizing, but really creating solidarity and support and community in a different kind of way. And you see that in LGBTQ centers, in a different way in campus intimate partner violence and sort of sexual violence prevention programs, often coming from a very strong kind of feminist perspective. And then very few campuses have disability cultural centers, but again, lots of parallels, program models that focus on integration or reintegration rather than removal and exclusion. And then greater student, faculty, and staff trainings focused on, really building understanding, empathy, and support, and decreasing this kind of default reliance on, oh, I'll just report somebody as a student of concern, or in some other way, I'll escalate what appears to be a crisis situation. So many of the interviews we did, I think, one of the mandated leave students who was the most harmed just experienced a panic attack in the middle of campus. In no way, shape, or form should that have led to involuntary hospitalization and then a forced leave of absence. It's just, ridiculous, but people didn't know what was going on, did not know how to respond appropriately, were not supportive, made the situation immediately worse, and then much, much worse through the actions and decisions that followed. And then just an idea I've heard some folks talking about lately is having more dedicated roles that are where the primary training of the individual is like facilitation, mediation, and de-escalation. Not so much trying to kind of clinicalizing in terms of mental health, but that a lot of the skills are just, really knowing how to talk to somebody who's distressed, how to maybe de-escalate the people around them or the friends as much as the individual potentially. And if we trained people with those skills, there could be kind of folks like that in campus environments who could really help prevent some of this default to campus law enforcement involvement, involuntary hospitalization, and then just kind of returning to the broader issues around disability and disability accommodations, just supports that go beyond that kind of minimal compliance, to focus on universal design and what the disability justice community increasingly refers to as radical access. Just a much more robust form of what it means to create accessible environments and programs for mentally, physically diverse folks. Oh, and I forgot to add Shira's email. You probably all have it from registration, but thank you all so much. And I think this still leaves us a good chunk of time for questions, discussion.
Yes, thank you so much, Nev, and thank you everyone for the thoughtful comments in the chat. So we can now begin the Q&A. I'm just going to look through the chat and see what questions we have, but feel free to just keep sending questions, comments. We'd love to hear from you. So the first question I see in the chat is, what access do campuses have to mental health first aid? Nev, do you want to take that one?
Sure. So I think this has been quite a discussion. I know people are here from like just a variety of different backgrounds. There's a lot of, I think, kind of debate within the user survivor community around mental health first aid. The campus I was at, actually the program Shira was in as well, we universally taught required mental health first aid as part of our program. What I will, just to give you a flavor of some of my experiences, students having gone through mental health first aid, then coming into a class with me, I disclose that I've been diagnosed with schizophrenia, and they say, well, based on what we just learned in mental health first aid, that's not possible. So, I think different diagnoses, because that's how mental health first aid is kind of organized, are treated differently. Some are better and some are worse. And if it's that easy for students who have been through mental health first aid to walk into a classroom and think it's not even possible to have an instructor with psychosis, I think that does tell you something about issues that mental health first aid is not doing a good job at addressing. Anecdotally, back when I was in California, a couple of the school districts I worked with in the San Francisco Bay Area that implemented universal youth mental health first aid training immediately saw a massive spike in police call-ins and involuntary commitments initiated through the school district, such that they discontinued mental health first aid training. And some of that could be a failure to really kind of think through the implications of mental health first aid training and nothing else. Arguably hyper alerts people to symptoms, to what are framed as symptoms, with not necessarily much in the way of skills to kind of think about that differently, handle it directly differently, sort of the default being, alerting professionals or initiating. So again, that's kind of my perspective. Not everybody agrees. There are advocates of mental health first aid, but I think it's definitely an issue to dig into more. This is going to be posted on YouTube. I feel like it's not public information, so I don't want to name the school districts, but would be happy to talk to anybody more offline. And there's one paper that I know of. This was an effort in Canada to try to look at some of the unintended consequences of mental health first aid implementation.
Yeah, thank you so much for that. And we have a question which kind of coincides with something I wanted to add, which is, did they replace it with anything else? And I will just say, the National Empowerment Center, we offer a program that is similar to mental health first aid in some ways, kind of designed for a somewhat similar purpose, but it doesn't really focus at all on like diagnoses or different types of symptoms. It really focuses on that skill aspect that Nev was saying is sometimes missing from mental health first aid. It focuses on just being present with people and supporting them through emotional crisis and just kind of developing a human to human connection with them. And that program is called Emotional CPR. I can put the link in the chat after I'm done talking about it, but it really it takes the position that anyone, no matter what their background, can support someone who's going through an emotional crisis. And there doesn't need to necessarily be this model of referring someone to a mental health professional immediately or calling 911. Obviously there could be a place for that, but it's really more about just people who are going through emotional crisis or having this natural response often to a traumatic situation or to something going on in their life. And we can just kind of listen and provide support. The ECPR stands for Connection, Empowerment, and Revitalization. So we really focus on like those kinds of processes as opposed to like identifying symptoms and trying to recommend specific forms of treatment. So I think that could be a really great alternative to mental health first aid. We have actually done that on some college campuses, most recently Holyoke Community College. So that's very exciting. So that's something we're trying to expand. And we really think at NEC that could really decrease the use of hospitalization or leaves of absence on campus. So I will put the link in the chat for anyone interested. Nev, did you want to comment on that about replacements for mental health first aid?
Yeah, I mean, I think this connects to Dan's comment, which is really great. I think so I'll just read Dan's comment because I think this gets at some of what, I too would recommend, although I don't think it exists. So, Dan, if you would ever have time to like sort of map this stuff out, but, so Dan just says, I think that in terms of getting people at these institutions to change their behaviors, it may be helpful to break it down into the granular precursor steps. So for instance, a lot of things happen before the person ends up involuntarily committed. Like you mentioned, ways to support someone experiencing a panic attack. And even then there are specific behaviors for a panic attack rather than lump summing it as a panic attack. So talking about how do you help someone with XYZ experiences may get them into a headspace to divert away from the involuntary leave path. Same thing with saying no coercion. Maybe there are specific things to advocate to stop coercion, like teaching them to lots of choices along the way, and that could stop them from restricting choices by coercion. So yeah, I just want to like really agree with that. And just some other examples would be quite often, so a whole kind of subset of these involuntary hospitalizations happened because somebody in the context of a big fight with their family, with their romantic partner, boyfriend, girlfriend, in the moment says, you leave me and I'm going to kill myself, or, I want to, cut myself right now, or I want to kill you, or I want to kill the girlfriend I just found out you were cheating with, or to their parents. I mean, especially like, teenagers, young adults just starting college, it's really common to be, having conflicts with parents. And so you just it gets really heated. You say the wrong thing. So that's it really has nothing to do with diagnosis, symptoms, any of that. It's, and that's one like kind of bucket of things. There is processing of trauma that's inadequate. So this was another whole cluster. People had close family members who had died, disappeared, been raped. I mean, all kinds of terrible things not happening directly to the individual, but to close family members. And they're trying to process that, and nobody around them really knows how to help or support with that. So I think the understanding, then just school stress for some, or not getting straight A's for somebody who that's how they see themselves, or, kind of think that their parents will only love them, for example, if they're perfect, and then they fail in what, to others might feel like, oh, that's not failure at all. So I think if one sort of like mapped out the realities, which are absolutely not just kind of constructing support around diagnoses, that these are human experiences that are common in young adulthood, and that as a society, we're not very good at kind of supporting or understanding how to de-escalate. And just to go back to Dan's comment, step by step, really breaking that down for people, because otherwise it all just becomes way too just generic, and things are just collapsed together that are really quite different, and everything is medicalized and clinicalized as mental health, when it is very often not. It's relationships, it's stress, it's developmental stress in the sense of like figuring out how to succeed in life or pick a major, or
Thank you so much. I see, Jane, you have your hand raised. So did you want to, I guess I can ask to unmute and you can speak up. We really are trying to just take comments from the chat, because that would be really hard if everyone spoke. Apologies, but Jane, I will ask you to unmute, but going forward, if people can just use the chat. Thank you so much.
Okay, thank you, Shira and Nev. Just kind of right to Nev's, what she was just sharing, because I was diagnosed in 1981, and I'm still recovering from those familial relationships, and took an Enneagram class through a church in April, and just in terms of healing, understanding each other, siblings, relational healing, the insight I gained from that class was profound. I'm in the emotional triad of numbers. My brother and my husband are in the body-centered triad, which they're most comfortable bicycling, hiking, not with the emotions. My sister's in the mental triad of numbers 5, 6, and 7. So she's more comfortable studying than dealing with my emotions. So I was pathologized from an early age. And really it was my step sister and stepmother that, bought into that pathologizing. And in terms of the ancestral healing and generational healing, and now the new movie out called Past Lives, I kind of feel like, I lost my mom to suicide in 1977 after discharge from El Camino Hospital, and depression. So with for psychiatric drugs. So anyway, I'm just wanted to offer that, whether we can even just give simple tools that don't require cost, purchasing the emotional CPR curriculum, perhaps even, to school districts and children, and that's sort of the idea. Thank you.
Yeah, I just want to say quickly, thanks. And I think there's, a few other comments that sort of echo the complexity of family or, kind of social network responses. In some cases, they're just bystanders, but we, again, like fixate so much on the individual, and then within the individual fixating on quote unquote psychopathology. And often, you know, that's sort of the first error, because that's, you know, that's not really responsible for what's going on. And then there's so little resources or supports for people, even in a good campus counseling center that does have quality programming. It's like vanishingly rare that they would provide, let's say, sort of mediation with parents, where parents might be a major source of conflict, concern, and stress, or, you know, other family non-members of the campus environment, right, of the campus community, so that these other family members are not eligible for any campus services. And, you know, it means that we're just not able to actually sort of address what is really going on for people.
Absolutely. We do have another question that hasn't been answered yet. Can't there be overdue support drop-in centers on campus and formal help?
Yeah, I mean, I think absolutely. I think one of the challenges is there's quite a bit of precedent now for kind of creating, in theory, sort of peer support drop-in, but within the campus counseling environment. And those very often basically include policies that require then pretty rapid escalation, right? So the student peer workers are not really accorded a lot of, they're certainly not deferred to. The idea is that they're not really in a position to assess or evaluate. So they're having to report students up the chain if anything concerning is said. Students in campuses like that know that that happens, and it sort of defeats the purpose. So I think kind of separating them out from campus counseling or student health facilities, you know, kind of hence thinking more about like the sort of the separate LGBTQ model, which does in many campuses also provide mental health support, but it's really its own thing, kind of separated out. And there's various versions of that for other minoritized groups as well, where it's not conflated with counseling and just sort of one layer under a counseling center. So I think it really, we need more like kind of models of doing that differently. And then in response to Matt's question, I did put the link to Project Let's, because they're probably the most active alternative user survivor-led group doing a lot of campus mental health work and organizing groups. So there's that side of it too, really, like where it's an independent entity that is, you know, working with students to develop kind of more grassroots alternatives on campus that are not funded or controlled by campus administrators.
Absolutely. We do have a comment that I thought was worth highlighting, and I don't know if Nav, you have any comments or responses to this, but I think that integrating lived experience is very important. However, this expertise is not really understood in system and policy design.
Yeah, I mean, amen. That's definitely like a huge problem. And you know, I think in campus environments, it's just so vanishingly rare to see integration of lived experience of disabilities. You know, it's just an area that just all disabilities really, really drop out, and there's often no student representation. Many campuses don't even have, like, you know, they'll even have like a women's interests or something, women's issues committee, but there's just absolutely nothing for disability. So it's sort of like at all levels, it's not just an absence of kind of peer support mechanisms, but also you just don't see lived experience involvement or representation. When Shira and I were at the University of South Florida, the Office of Disability Director was actually a disabled activist, and it made a huge difference. I have never been at another campus where the director even had a disability, much less, really occupied and owned the identity of sort of activists and advocates. So even that, which you would think would be really looked down on, right, is hiring a director of disability services who themselves isn't even disabled, but that is absolutely the norm. And then if they're the only appointed person who represents disability on, let's say, a diversity committee, you literally have just essentially excluded actual disabled disability representation. So definitely there's just a lot of need to really kind of think about that and how we can build cultures within campus communities that value that.
Definitely. So I think we have time for one more quick question, and I know, Shira, you have your hand up, so I'll go ahead and unmute you. But then we'll need to wrap up.
Yeah, sorry. It's just, this is such an important topic for me because I am a person with a disability, and I have been in institutional settings where my lived experience was stigmatized and really undermined in a lot of ways. And the challenges that I face kind of maneuvering through a system that actually disables me. So, advocating for my lived experience in along with my professional and academic relatability, I suppose, was really challenging because it automatically put me in a position of inferiority to the administrators who were not disabled, right? So, and being the disability that I have is an invisible disability as well. So there's another layer of stigma that is present there because I look, sound, and present as somebody who is highly capable. And so then advocating for accommodations and my needs in order to advocate for my accommodations and needs, it's like this vicious circle. And so it really is a systems issue. And I think that the underlying kind of root of that is this, and I'm sorry, I'll stop right after this because I can go really in deep on this, but is this administrative hierarchy that we have in all of our systems, in our school systems, in our healthcare systems, in our government systems. And I think that if we start to work on that and start really working on how we navigate leadership in these structures and what that looks like, which I think is more facilitative and transformative and restorative leadership, then we can start thinking about how my voice will ever be heard in those spaces, basically.
Thank you so much.
I that's a really powerful note to close on. Yeah, I mean, we want to change things so that like these experiences that you've had are not what is just, semi-pervasively facing students with disabilities. And it's just so heartbreaking, even when one has experienced it oneself, to just be hearing this and seeing this in other people. And so
it's traumatizing. And my community, I also get the vicarious trauma because I'm in the autistic community. And so the intersection of I'm white, I'm a woman, there's some privilege that comes with that. There are many autistic, highly intelligent, innovative, creative people that voices are not being, my voice isn't being heard, then their voices aren't being heard, that can really make a huge difference in our educational systems. And so just something to think about. I don't know the answer to that. I'm trying, but I don't know the answer to that.
yeah, well, thank you so much. And I mean, thank you everyone for being here. Anybody, I work on a variety of projects around kind of systems change. So if anybody is interested, please feel very free to just email me and follow up, and I can link you into other stuff I'm involved with, because I just always feel bad. Like, we have this great discussion and then the webinar just ends, but it really, there's a lot of work that actually needs to continue. And, you know, the more that we can all join forces, the more we'll be able to accomplish.
Thank you so much.
So I just put my email in the chat.
Well, thank you so much, Nev, for presenting, and thank you all of you for being here. I just so appreciate all the comments and great questions and discussion. And we will be sending out the recording, the PowerPoint, and the certificate of attendance, as well as a follow-up survey on the webinar. And we will, of course, be sending out information about our next webinar in the series too. So hopefully you're all on our mailing list, or we'll add you so you can get that information. And we hope to see you at the next webinar, and hope you have a great rest of your day. Bye, everybody.